Assalamu alaikum, everyone. My name is Mustafa. I'm a second year med student, and with me,
I'm Nour Bajawi, a second year medical student also.
and today we will be giving you guys an OSPE crash course on MSK. Now, before I get started with the material we'll be covering and the reason why you guys are here, basically, I'd like to congratulate you guys for nearly finishing your first year of med school. Give yourselves a pat on the back. You guys deserve it. Now, this past year, you've probably gone through a bunch of ups and a bunch of downs. But what's most important is that you guys have prevailed and you're here right now. So be proud of yourselves. Now, you're probably looking at this exam season and feeling stressed or maybe even scared. But you guys have been here before. You guys have had an exam season in the winter. And this exam season is the same thing. We have exams. Third years have exams. Med students all around the world are feeling stressed right now. So inshallah, we all get the results that we want and deserve. But sorry to rain on your guys' parade. This OSPE is probably going to be one of the harder OSPEs you experience in your first year of med school. But hopefully, after this crash course, me and Nour will cover all the material you need to ace it, inshallah. I still would suggest you guys go through your lab committee material because the more you study, the better outcome. But we will try to cover everything in this crash course. If you're a crammer, this should be enough. So let's get started. And by the way, if you guys have any questions, here are our contact details, our email and our number. Feel free to contact us if you have any inquiries regarding MSK. So what we will be covering today is the anatomy of the upper limb. I'll be covering half of histology, whilst Nour will be covering the anatomy of the lower limb and covering a couple of questions after. Now for the upper limb. I'll be covering the clavicle, the scapula, and the humerus. So let's look at the clavicle, this weirdly shaped bone. We could see here, or we could appreciate it as two sides, the sternal end and the acromion end. And these two sides are different, or these two ends are different. The sternal end is known to be more round in shape, whilst the acromion end is known to be more straight in shape. What we also can appreciate is that both of the surfaces, superior and inferior, are different. The superior surface is known to be really smooth, right? Whilst the inferior surface is known to be pretty rough. The reason why it is rough is because it has a lot of impressions, tubercles, and even a trapezoid line. And this impression right here is where the costoclavicular ligament will attach to, the ligament which connects the first rib to the clavicle. It also has a coinoid tubercle and a trapezoid line, which are the insertions for the coracoclavicular ligament, which is a really strong ligament. Let's look at this picture right here. Now, this picture was provided from your lab committee. It has the ligaments that kind of support the clavicle and keep it in its place. You could see the trapezoid ligament and the coinoid ligament, which both of them together make up the coracoclavicular ligament. You also have the acromioclavicular ligament, which connects the acromion process of the scapula to the clavicle. We also have the coracoacromial ligament and even the costoclavicular ligament right here, which connects the first rib again to the clavicle. Now, all these ligaments, their role is to kind of stabilize the clavicle, keep it down. And this is why the inferior surface of the clavicle is pretty rough, because all of these ligaments kind of attach to it. Now, in cases of a clavicular fracture, let's say you've fallen down on an outstretched arm. The most common place for a fracture to occur in is the junction between the medial 2/3 and the lateral 1/3. The reason for this is because there is a strong muscle which attaches to this part of the clavicle, the medial 2/3, and the lateral 1/3 is, pulled down or stabilized by these ligaments that we talked about before. The reason why the medial fragment goes up is because the sternocleidomastoid muscle, which is a really strong muscle, pulls it up. And this is why they kind of separate up and down. The medial or the lateral ligament right here is pulled down by these ligaments and also muscles known as pectoralis and the subscapularis. Now in the exam, if they ask you, where is the most and the lateral 1/3, and if they ask a bonus question on what muscle pulls up the medial 2/3 of the clavicle, it's the sternocleidomastoid. So here is a summary of what I just said. The clavicle has two different ends, the sternal end and the acromion end. One of them ends is known to be round, the other end is known to be flat. The inferior surface is rough, whilst the superior surface is smooth. A fracture is most likely to occur between the medial 2/3 and the lateral 1/3. And here are the ligaments which kind of stabilize the clavicle. Let's move on. Now for the scapula. Now the scapula is an interesting bone. We can apply a rule of 3 to it. It has 3 angles, 3 borders, and 3 processes. The 3 angles being the superior angle, the inferior angle, and the lateral angle. Now the lateral angle is important. It forms the glenoid cavity, which is where the head of the humerus will insert into to make the ball-on socket joint. It has 3 borders too, being the superior surface, the inferior surface, and the lateral surface. It also has 3 processes, which is very important. It has the coracoid process, which is right here. It has the acromion process, which is right here. It also has a spine that runs through the middle. Now, you can't see the spine on this picture, so let's go onto this picture. The spine is this structure right here. It separates the back of the scapula into 2 different fossas, the supraspinatus fossa and the infraspinatus fossa. And they serve as like a space where the rotator cuff muscles can insert into. What's important for you guys to remember too is that there is a notch right here, the suprascapular notch, which is a space on the superior border of the scapula, and it allows an artery and a nerve to go through it, being the suprascapular artery and the suprascapular nerve. And this nerve and artery will go on to supply the supraspinatus and the infraspinatus. And you can see them going through the space right here. The artery is on top of the nerve because if it were to be under the nerve, it would kind of get, strangulated or compressed. And whenever the artery needs to expand to accommodate more blood to the muscle, now it has space to because it's on top of the nerve. You can remember this by Army Up, Navy Down. That was provided by a lab committee. But yeah. Now let's move on. Now the scapula is or provides the glenoid cavity. As we said, the lateral angle of the scapula forms the glenoid cavity, which is where the head of the humerus will insert into this space right here. It has a tubercle on top of it and below it, being the supraglenoid tubercle and the infraglenoid tubercle. These 2 tubercles serve as an insertion for 2 muscles, being the long head of biceps tendon and the long head of triceps tendon. Now, is this too relevant for your OSPE? I'm not sure. I do remember though last year in the MCQs, they asked the question, I think it was regarding a clinical scenario where the supraglenoid tubercle was damaged and which of the following other structures were highly likely to also get damaged. And the answer was the long head of biceps. So it might be important to keep on the back of your head that there are 2 tubercles on top and under the glenoid cavity, and they serve as insertions for 2 muscles. So here's basically what I discussed. The scapula has a rule of 3, being the superior, or being 3 angles, 3 borders, and 3 processes that it has. It also has the glenoid cavity, which is formed by the lateral angle of the scapula, and it has an artery and a nerve that go through it, the artery being on top and the nerve being under. Now for the humerus. Now, the humerus is an interesting bone. We can first admire that it has a humeral head. It has 2 tubercles, being the lesser tuberosi and the greater tuberosi, seen right here, and it has a groove in between them, being the intratubercular groove or the intertubercular groove. This groove is important because a tendon goes through it, being the long head of biceps tendon. Now you're probably thinking, right, Mustafa talked about this tendon a couple minutes ago. The long head of biceps tendon actually goes up this groove and inserts on top of the head of the humerus into the supraglenoid tubercle. So this might also be, a question they could ask on the OSPE. They could like put a pin on a tendon that goes through this tubercle and attaches to the supraglenoid tubercle, and they could ask you what it is. The long head of biceps tendon. Remember that. Now for the humerus. Now they could ask a silly question. Right? Yo, is this humerus the right humerus or the left humerus? It might sound silly, but a lot of the questions they do ask are sometimes silly. No offense, but let's look at how we could tell whether or not this is a right or a left humerus. We have to make sure that we're looking at the front of the humerus, or the anterior aspect of the humerus. We could tell this, or we could tell that it is anterior or posterior by looking at the coronoid fossa, the capitulum, and the trochlea, right here. Now, the capitulum and the trochlea serve as insertions for the ulna and the radius to attach to the humerus. We could also look at the if there is a deltoid tuberosi or not. Now, if there is a delta tuberosity, that means we're looking at the back of the humerus. So this is the posterior aspect of the humerus, and this is the anterior aspect of the humerus. Now we know like that we're looking at the anterior aspect and the posterior aspect. Why is this important? So when we're looking at the front of the humerus, so the anterior aspect of the humerus, the head of it, or the head of the humerus, is facing in the direction of the body. Let's say this is Ali right here. This is his right humerus. And we could also tell by the medial epicondyle, which is right there, it's also facing the right side, which means that this is 100% the right humerus. Now the head is facing the left and the medial epicondyle is facing the left. We already said that this is the back of the humerus because we could see the deltoid tuberosity and also this space called the olecranon fossa, which is a big space that's present on the back of the humerus. And this is basically this humerus flipped over because we could see that everything's facing the opposite direction and we made sure this is the back. So if they ask you a dumb question like that, use these like this technique, this word technique that I just talked about, and you'll get it and not lose no more. Now, for the bottom part of the humerus, we have the olecranon fossa, which is this big space in the middle. And we'll be talking about its function later. We have the trochlea, which is under it, and the trochlea serves as an insertion for the ulnar bone. So the ulnar bone connects to the humerus via the trochlea, and the capitulum serves as an insertion for the radius, the radial bone. Now, the olecranon fossa is the space right here that's present on the back of the humerus. Its function is whenever you overextend your arm, right? The reason why you can't extend it even further, let's say like above 180 degrees, is because the ulnar bone has a olecranon process, which is a piece of its bone which kind of hits this fossa, which prevents it from, overextending. So the reason why you can't overextend or why your arms have a limit to the amount it can extend is because the olecranon process of the ulnar kind of inserts into the space. So it might be important for you to keep in the back of your head. Now, for the most like relevant info that you guys need to know. So the humerus is a common bone that's fractured, and it has three types of fractures that you guys should remember. The fracture of the surgical neck, which has structures that can also be damaged alongside it, being the axillary nerve and the posterior circumflex humeral artery around this area. Now, a fracture of the humeral shaft, which would occur around here, would lead to the radial nerve and the deep brachial artery being damaged. Now, in a supracondylar fracture, being around this area, it will lead to the median nerve and the brachial artery being damaged because they run in very close proximity to this area. Now, this info, is not only important for your OSPE, but it is very important for your MCQs and SAQs. So please try to remember them any way you can. Now, the humerus or the ball and socket joint is supported by a lot of different things, a lot of different ligaments too. It's supported by the coracohumeral ligament, which is right here. It's supported by glenohumeral ligaments, both inferior and superior. It's also supported by a transverse humeral ligament, which is not visible on this image right here. So it's a supported joint. What it also has is a labrum, a glenoid labrum. Now, this pink thing right here, it is inside of the glenoid cavity. Now, firstly, the glenoid cavity, which is the hole that's present in the scapula, it's really shallow. It's not that deep. And if it weren't for this labrum right here, the humerus's head would fall out of this cavity easily. What this labrum does, right, it kind of goes around the humerus's head and kind of stabilizes the strain, giving the impression that this glenoid cavity is deeper than it actually is. So it kind of, stabilizes the joint. What also kind of, stabilizes or supports this joint or the humerus is these group of muscles called sits, or these rotator cuff muscles. They consist of the supraspinatus, the infraspinatus, the teres minor, and the subscapularis, kind of around here. But what we can see is that the bottom of the humerus and the anterior aspect of the humerus is not supported by these muscles. And this is clinically important. The most common dislocation, or the shoulder joint, is the most commonly dislocated joint of our whole body. And the most common type of dislocation of the shoulder joint is the anterior dislocation. And the reason for this is because it's not as well supported by the sits muscles at this area, the anterior and inferior aspect of the joint. But whilst the posterior dislocation is less common than the anterior dislocation, and it kind of looks like a light bulb, if you guys could see. It looks pretty weird, like the head of the humerus is not fully out of the socket, but it's dislocated. Whilst here, you could see that it's way it's very far from the socket. So just remember the light bulb appearance whenever you look at an X-ray. And if they give you this X-ray, you probably would know 100% because the head is nowhere near the glenoid cavity. Now, the humerus, for summary, I talked about the heads, the tubercles, the grooves, the condyles. The head faces medially. The intertubercular groove has the long head of biceps tendon that goes through it. The most common fracture sites, you guys should remember them, please. And the sits muscles stabilize the head, as well as tendons or ligaments, sorry. And the most common dislocation is the anterior dislocation. Let's move on. Now it's time for the muscles of the upper limb. So for this section, you'll be looking at a lot of cadaver pictures because in the exam, you will mainly be presented with cadavers or models. So an important important advice for this section would be to look at as many pictures as you can, because visualizing the structures that surround whatever is labeled will help you kind of, remember what structure it is instead of just purely memorizing it. So we will be getting into or looking at the back region muscles, the pectoral region muscles, the shoulder region muscles, the neck region muscles, and intramuscular spaces, which is also important. So make sure to concentrate on this. Now for the back region muscles. You first looking at the trapezoid or the traps. Now the traps, this is big muscle right here. It's huge. And it has three types of fibers. It has the upper fibers, sorry. It has the middle fibers right here. And it has its lower fibers right here. Now, each of these fibers have different functions. The upper fibers pull the scapula up. Now, they're inserted really high, and they're also inserted into the scapula. So it would make sense, right, that it would pull it up because it's pulling it to its level. So you guys can kind of guess or get the function of the muscle by just remembering the insertion of it. Now, heads up for the middle fibers, it inserts into the scapula right here and the middle of the spine. So what it does is that it brings the scapula together and closer to the spine. The inferior fibers, what they do is that they pull the scapula down. They're inserted really low, right here, and they're inserted into the spine, or right here, or the scapula, sorry, and they pull it down. So, remembering the insertion of each of the muscles can actually help you in the final and kind of guess the function of the fibers, of the trapezoid. Now for the latissimus dorsi, right? The latissimus dorsi is a really big muscle too. It inserts into the intertubercular groove and, kind of gives this wing type shape. And it is an important muscle to remember. It has a couple functions. It has extends the arm, it adducts the arm, and immediately rotates the arm. So if it's connected to the medial aspect of the arm, thinking that, it medially rotates, it adducts, so it brings the arm closer to the body, and it extends it, it's kind of because of its insertion, right? It's inserted medially. So again, insertion can kind of help you guess its function too. So now for these two groups of muscles, the rhomboid and the levator-scapular muscle. Now the levator-scapular is the small muscle right here. It inserts pretty high and inserts into the superior angle of the scapula. And it does what the name says, it elevates the scapula, it brings it higher. The rhomboid muscles, their role is to retract or bring the scapula closer to each other or close to the spine. You can see here that they're inserted in the middle and inserted into the lateral aspect or the lateral border of the scapula. So they kind of just, bring them together. And on the cadaver, they're not really visible because they're covered by the traps and the latissimus dorsi. But I don't think they would ask you on this. But if they do, just remember that the major is bigger than the minor, and they kind of lay right onto the trapezoid muscles. So now for the pectoral region muscles. So firstly, for the pec major. Pec major is this big chest muscle right here. It inserts into the sternum, or the ribs, sorry, and then inserts into the intertubercular groove of the humerus. And its role is to flex, adduct, and medially rotate the arm. So again, its insertion kind of is associated with its function. And it's this big muscle right here. If they ask you on in the OSPE, You guys will know just by looking at it, that's the pectoralis major. It covers most of the chest and inserts into the humerus. Now for the pectoralis minor. Now, all minors or all muscles that have minors, they're always behind the majors. The majors are the big bros. They cover it all. So the minors are behind them. The pectoralis minor inserts into the ribs and also inserts into the coracoid process or the coracoid process. And its function is to protract the scapula. So protraction of the scapula is when the scapula is being pulled away from the spine or the midline of the body. And this is kind of because it inserts into one of the lateral processes of the scapula right here, and it's inserted into the front aspect of your body. So kind of like pulls it to the side, kind of. And it's involved in downward rotation of the scapula, and it elevates the ribs too. So it's this muscle right here, present on the cadaver. And again, it's kind of covered by the major. So the solar muscles, let's get into them. We have the rotator cuff muscles, which consist of 4 different muscles: the supraspinatus, the infraspinatus, the teres minor, and the subscapularis. So the supraspinatus, being this muscle right here, inserts superiorly, and its function is to initiate a abduction till 15 degrees. So like when you raise your arm, it kind of just initiates the first 15 degrees, and then the rest of the movement is done by the deltoids, the big bros. The deltoids kind of, abduct the arm till the 90th degree. And then after that, it's done by the serratus anterior and other muscles. But you don't need to know that for the OSPE, I think. The infraspinatus and the teres minor, they are right here. They kind of insert into the same place. And they do the same thing. They laterally rotate the arm. The subscapularis is not seen on this cadaver. It's not labeled at all. And the reason for this is because these 3 muscles, the supraspinatus, the infraspinatus, and the teres minor, they insert into the same place. They insert right here. They insert into a place called the greater tubercle. Now, we talked about that, right? Whilst the subscapularis inserts into the lesser tubercle, which is kind of right here. So you could kind of, see where I'm going with here. Like the muscles, they insert into a further area than the subscapularis. So they kind of cover it. So on the cadaver method, you wouldn't see it unless you turn the muscle forward or you look at the scapula from an anterior aspect. And here is the subscapularis. The infraspinatus and the supraspinatus are behind the scapula, whilst in front we have the subscapularis. And its function is to medially rotate the arm or the scapula, sorry. Now for the neck region muscle. There's only one main neck region muscle you need to know. That is the sternocleidomastoid. You could look left and then right, and then it'll kind of contract. It helps with looking around the vertical axis. And remember, this muscle is the one that pulls up the medial 2/3 of the clavicle in a clavicular fracture. And that's about it for this muscle. Now, the intramuscular spaces. So this is an important section, and this is important info you guys need to remember. So please try to lock in. We've got 3 different spaces, right? We've got the triangular interval and the quadrangular space and the triangular space. Now we're going to be looking into the quadrangular space. So the quadrangular space is a space right here. It has 4 different borders. Its superior border is formed by the teres minor. Its inferior border is formed by the teres major. Its medial border is formed by the long head of triceps, and its lateral border is made up by the surgical neck of the humerus. The quadrangular space has 2 structures that go through it, being the axillary nerve and the posterior circumflex humeral artery. Now, a good way for you guys to remember that these 2 structures go through it is that when we discussed the fractures that are associated with the humerus and the structures which are prone to being damaged in each fracture, we talked about how in the fracture of the surgical neck, that the axillary nerve and the posterior circumflex humeral artery are very prone to being damaged. This is because they run really close to it. So they run really closely to the surgical neck of the humerus. And the surgical neck is one of the borders for this space right here, the quadrangular space. So you could remember, right, that in one of the boundaries, it's being fractured could lead to these structures being damaged. So therefore, they're really close to each other. So the axillary nerve and the posterior circumflex humeral artery goes through this space. If that helps you remember it, then you could use it. Don't worry. So now for the triangular space. Now the triangular space, it's in the name. It's built like a triangle. It's only got 3 borders. Its superior border is the teres minor. Its inferior border is the teres major, and its lateral border is the long head of triceps right here. and only one structure goes through it, being the circumflex scapular artery. And this artery supplies majority of the scapula, anastomizes with a bunch of different arteries, and is important. So that's it for the triangular space. Now to the triangular interval. So the triangular interval has 3 boundaries, but this time something's different. The superior border is not the teres minor anymore. Oh no, it's the big bro, it's the teres major. Teres major is the superior border of this space now. Now the lateral and the medial border is formed by the same muscle, but just 2 different heads. It's made up by the lateral head of the triceps, making up the lateral border, and the long head of triceps, making up the medial border. And it also has 2 structures that go through it. It has the radial nerve and the deep brachial artery that actually go through it. Now, a good way to remember that these 2 structures go through this space is that 2 of the borders of this space or of this interval is formed by the triceps. Now, the triceps is a major extensor of the elbow, and it is supplied by the radial nerve. Now, the radial nerve supplies all of the extensors of our upper limb, and it will supply the triceps itself too. So a nerve going through a space which is made up by the muscle it supplies could kind of, help you remember that the radial nerve goes through the space. And where the radial nerve is, the deep brachial artery is also. So they run really closely to each other, and you could remember it like that if you would like to. So here's the intramuscular spaces again. We have the triangular interval, the triangular axillary space, the quadrangular axillary space, and the structures that go through them. Now, here is an amazing picture provided by a lab committee. You could use this in the exam, to help remind yourself of the boundaries, the structures that go through it, and stuff like that. Here's a cadaver picture. Here's the triangular space, the quadrangular space, the triangular interval. Now, the quadrangular space and the triangular space are on the same level, whilst the triangular interval is kind of below it. Now for the arm. We'll be first getting into the bones of the arm. So the arm, the forearm, has 2 different bones, as the radius and the ulnar. Now, how can we differentiate these 2? The ulnar has this olecranon process, the one that inserted into the olecranon fossa that we talked about before, and it's kind of shaped like a bathroom, Loki, right? So that could help you remind you that this is the ulnar. What's also visible, or what you also can identify, is that the top part right here is much thicker than the bottom part. Bottom part is really skinny, whilst the top part's pretty thick. The radius, on the other hand, is the opposite for it. Its bottom is really big, and its top is pretty small and organized. It looks nice. So what you also need to remember, right, is that the radius has an important clinical implication that occurs with it, being Colles fracture. Now, Colles fracture is a fracture that occurs at the styloid process of the radius. Okay, so they could ask what bone is this? It's the radius. What fracture is associated with it? Colles fracture, and then they could even put different labels on different areas of the radius and tell you where's the most common fracture. Where does the most common fracture occur at? So another question. Now for the carpal bones, I don't think this section is really relevant, but they might ask a question on it, so I decided to include it. Now the clinical, there's 3 carpal bones which have clinical implications with them. You've got a scaphoid bone, which is this bone right here. When it's fractured, it could lead to the radial artery also being damaged, leading to avascular necrosis or the bone kind of dying. Now, the lunate bone, which is right here, is the most common bone that's dislocated. And it's being dislocated could affect the median nerve. The fracture of the hamate bone is also common, and it being fractured would lead to the ulnar nerve being prone to also being damaged. So they could low-key, label one of these 3 bones and be like, what clinical implication does it have? Or things like that. Which of the following bones is most commonly dislocated? And maybe this is labeled B, so the answer would be B. In case if they do, then just remember these clinical implications. I think it's also important for the MCQs and SAQs too, so please try to remember that. Now let's move on to the metacarpals. Now, there's not much for the metacarpals. There's 5 of them. There's a couple muscles that attach to some of their joints, like here and here. But apart from that, nothing much. The phalanges are these extensions of the metacarpals, and they also have tendon or muscles that attach to their joints. And yeah. Now for the brachial plexus. Now this section is also high yield, and we need to, say lock in for this section. So the brachial plexus, what you need to remember is the big M. Big M being this one right here. Now, what forms the big M? Let's look at the cadaver, right? You can see the M is formed by 3 different nerves. It's formed medially by the ulnar nerve right here. Okay? And it's formed in the middle or the middle V shape right here. Let me just draw it. The middle V shape is formed by the 2 branches of the median nerve. So the median nerve is formed by a branch of the lateral cord and the medial cord. And it's kind of like this. These 2 branches give off to one nerve. And this nerve is the median nerve. So this is the median nerve. And then the lateral line of the M is formed by the musculocutaneous nerve right here. So ulnar nerve, median nerve, and then ulnar nerve, or musculocutaneous, sorry. And another important nerve you guys need to remember is this one on the back right here. It's the radial nerve, or the radial nerve. Now, I couldn't find a cadaver picture that kind of displayed the radial nerve, but they could, methylene in the OSPE, they could like raise the M, and they could be pointing at a nerve that is under or like behind this M. And this nerve is most likely to be the radial nerve, coming out of the posterior cord, comes out posteriorly behind this M, and supplies all the extensors of the arm. So they could bring a picture lifting the M. They lift the M in the cadaver, and there's a nerve that's coming under it. It's probably the radial nerve. So remember that. Again, here is the M right here. And it's formed by these nerves, the musculocutaneous nerve, the median nerve, and the ulnar nerve. Now for the upper limb flexors. So firstly, the big bro, biceps brachii. It flexes the elbow. It's the biggest flexor of the elbow. It has 2 different heads, the short head and the long head. And it's kind of here, it's kind of torn off. I don't know why they tore the biceps off, but it's very noticeable, and it's supplied by the musculocutaneous nerve. If you see 2 heads and it's present on the front, it's probably the bicep. Now for the brachioradialis. Now, quick fact, like the brachioradialis is supplied by the radial nerve, and only extensors are supplied by the radial nerve, but this is the exception, the brachioradialis. It is a flexor, or it flexes and pronates the arm, or pronates the elbow, sorry, but it's supplied by the extensor nerve, the radial nerve. Now, we could also see, right, between the brachioradialis and the brachialis, there is a nerve that's going through it, being the radial nerve. And in the OSPE, if they give you a picture of an arm, they have this big muscle on the side right here, and they have this flexor right here, and there's like a structure in between them. It's probably the radial nerve they're pointing at. So remember that. Now for flexion and pronation at the elbow, for any of you guys that go gym, doing hammer curls, this is basically working the brachioradialis, and it's this function basically. And it's supplied by the radial nerve again. So for the flexors of the forearm, it has 3 different layers: the superficial layer, the intermediate layer, and the deep layer. We'll be getting into each of these layers and dissecting them. Now for the superficial layer. So the superficial layer can be remembered by this small trick. I think Adif talked about like 27 times for us, but he talked about how you can kind of put 4 fingers on your forearm and then say pass, fail, pass, fail. And those are the muscles of the forearm, the superficial layer. The first P being for the pronator teres, the flexor carpi radialis being the second fail, the third pass being the palmaris longus, and the 4th fail being the flexor carpi ulnaris. Now for the pronator teres. So the pronator teres is a small muscle right here. It goes from the medial epicondyle to the radius and kind of goes across the bone, inserts into the radius. As you can see here too, it kind of goes from the medial epicondyle and inserts into the radius on the side. And its function is to pronate the arm mainly. And it's also a flexor, but flexion is its secondary role. Its main function is to pronate, which is in the name, right? Pronator teres. And it's innervated by the median nerve. So the flexor carpi radialis is this muscle right here. It's right next to the pronator teres. Okay? And on the cadaver, that's here, it kind of covers the pronator teres too because it's much bigger than it. But if you see a muscle that's kind of under the flexor carpi radialis and it's inserted into the radius and also the medial epicondyl. Then this is the flexor carpi radialis. Also, as a quick tip, when you think radialis, think thumbs. So all the muscles that have radialis at the end of it and head to the radial bone, they're present on the thumb side. When you think ulnaris or the ulnar bone, think the pinky, because they're on the pinky side. The flexor carpi radialis is innervated by the median nerve too. The palmaris longus is the most noticeable muscle of the flexor compartment. It has a really big tendon right here. And heads here on the cadaver, it has a really long tendon and it's really big. Its main function is to kind of tense up the palmar aponeurosis. And whenever you want to grip something, right, like pick up a water bottle, it kind of, aids with the grip and contracts the aponeurosis. And it is also innervated by the median nerve. Now, the flexor carpi ulnaris, again, when you think ulnar, think pinky. It is present on the side of the flexor compartment, right here. You can't even see on the model because of how medially it's placed or how on the edge of the compartment it is placed at. It flexes the wrist and it is innervated by the ulnar nerve. Now, this is one of the only muscles that is innervated by the ulnar nerve in the whole flexor compartment. Majority of it is innervated by the median nerve. This muscle and one other muscle are supplied by the ulnar nerve, okay, partially. But this one is fully supplied by the ulnar nerve. We'll be getting into that in a bit. Now, for the flexors of the forearm, we have the intermediate layer too. Let's look into it. We only have one muscle of the intermediate layer, being the flexor digitorum superficialis. This muscle is this muscle right here, by the way. Once the superficial layer muscles were removed, you could kind of see it. At on the cadaver, you have to lift up the palmaris longus in order to see it. And its role is to flex the PIPs and the MCPs, being the proximal interphalangeal joint and the metacarpal phalangeal joint. And it is innervated by the median nerve. Now for the deep layer. So the deep layer, it's right here. It consists of three muscles, by the way. The flexor pollicis longus, the pronator quadratus, and the flexor digitorum profundus. So the flexor digitorum profundus, it flexes the DIPs, or the distal interphalangeal joints. So these joints right here, okay? And it is innervated by the median nerve and the ulnar nerve. Now, this is the other muscle that I was talking about, the other muscle that receives innervation by the ulnar nerve, but only receives partial innervation by the ulnar nerve. The tendons of this muscle that attach to the pinky at this joint and the ring finger at this point, the distal interphalangeal joints, those ones are supplied by the ulnar nerve. But these three other fingers, the thumb, the index finger, and the middle finger, those are supplied by the median nerve. Now let's carry on. Now, the pronator quadratus and flexor pollicis longus is, I don't think it's too high yield, but head to the pronator quadratus can't be seen on the model properly, but its function is in the name. It pronates the forearm or pronates the wrist. The flexor pollicis longus inserts into the thumb and flexes the thumb at the interphalangeal joint. So the thumb only has one interphalangeal joint. It doesn't have a distal or a proximal, it just has one. And that is flexed by this muscle, the flexor pollicis longus. And this is supplied by the median nerve, to be specific, the anterior interosseous. Now for the cubital fossa. This is also high yield, and you guys should remember the structures that are going through it and the borders too. First, let's get into the borders. Now, the medial border of the cubital fossa is formed by the pronator teres, right here, and the lateral border is formed by the brachial radialis. The superior border is made by an imaginary line that is formed between the two epicondyles, the medial and the lateral. Now, you've got four structures that go through the cubital fossa, and they can be remembered by this acronym right here, MBBS. M standing for the median nerve, which runs right here. B standing for the brachial artery, which also runs through this space. B, the second B, standing for the bicipital tendon, that also goes through the space, and the superficial branch of the radial nerve that also goes through the space. So it's important to remember the structures that go through them and the borders that surround this space too, or this fossa. Now for the upper limb extensors. So we have two different layers to the extensors. We have the superficial layer and the deep layer. Let's get into these muscles now. For the superficial layer, firstly, we'll be talking about the extensor carpi radialis longus and the extensor carpi radialis brevis. Yep, they're really long names, tongue twister. But let's look into this cadaver right here. The extensor carpi radialis longus is this long muscle right here. Whilst the extensor carpi radialis brevis is this kind of shorter muscle right here. Now, again, over in this cadaver, the extensor carpi radialis longus is this really long muscle right here. Whilst the flexor carpi radialis brevis is this thicker one right here. But tattoo, you can see that the brevis kind of covers the brevis longus. Wait, no. The extensor carpi radialis longus kind of covers the extensor carpi radialis brevis. The extensor carpi radialis brevis is kind of thicker. So that's how you can like differentiate the two. And the brachial radialis, the big flexor, the fake extensor, is kind of on the side of these two muscles. So when you see the brachial radialis, just know the extensor carpi radialis longus is kind of right next to it. And the brevis is kind of covered by the longus. On this cadaver too, you can see that the longus is pretty long and the brevis is kind of under it on the bottom right here. And its function, or both of their functions, is to extend an AB duct to the hand, and they are innervated by the radial nerve, to be specific, the posterior interosseous nerve. So the extensor digitorum is the most noticeable muscle. If they were to ask you a question on the extensors of the forearm, it would probably be this one right here. Now, this muscle inserts into 4 of the phalanges, inserts into the ring finger, the middle finger, the index finger, and head of the thumb. Inserts into 4 fingers. Sorry for my terrible drawing. What its function is that it extends the digits at the MCP, being the metacarpophalangeal joints, or your knuckles. And it joins all of the knuckles apart from the pinky. It joins all of the MCPs of the fingers apart from the pinky. And it is innervated by the radial nerve, again, the branch of it being the posterior interosseous nerve. So when you see like a muscle that has tendons to all of the fingers apart from the pinky, think this muscle, the extensor digitorum. Now for the extensor digiti minimi. Now this muscle attaches to the pinky finger. Digiti minimi, small finger, if you guys want to remember it like that. The extensor digiti minimi attaches to the baby finger, or the pinky, sorry, and extends it at the MCP, again, the knuckle, kind of allows it to move, or extensor it. And this is innervated by the radial nerve, again, the posterior interosseous nerve to be specific. And it kind of runs, it runs right next to the extensor digitorum. So if you see a muscle extending its tendons to all of the fingers apart from the pinky, and a muscle extending its tendon to the pinky, then it's the extensor digiti minimi. Now for the extensor carpi ulnaris. Now again, when you think ulnaris, think pinky. And the extensor carpi ulnaris is right under the extensor digiti minimi. They're running close proximity because they're both, the extensor digiti minimi extends its tendon to the pinky, whilst the extensor carpi ulnaris supplies that area, and it extends an adduct arm. It's also innervated by the radial nerve and the posterior interosseous nerve, to be specific. Now here's a picture of all of the muscles again in this cadaver. We have the extensor carpi ulnaris right here. We have the digiti minimi, which is right next to it. The extensor digitorum, the biggest of both, it's really big muscle. It goes into all of the fingers apart from the pinky. The extensor radialis brevis, or extensor carpi radialis brevis, which is kind of covered by the extensor carpi radialis longus, and it's more thicker than it. Extensor carpi radialis longus being really long, extending, and right next to them, you got the big fake extensor being the brachial radialis. Now here's a table that denotes all of its functions. I will not read through them. If you guys want to go through them, be my guest. Let's move on though. Now let's get into the deep layer of the forearm extensors. So for the deep extensors of the forearm, we have 4 muscles. Yeah, 4 muscles. And all of them attached to the thumb. All of them attached to the thumb, apart from one muscle being the extensor indicis, which attaches to the index finger. It's in the name, right? Indices. The other muscles attached to the thumb at different areas though. The abductor pollicis longus is really long. It comes from the ulna and then attaches to the proximal interphalangeal joint, whilst the extensor pollicis longus kind of attaches to the distal interphalangeal joint, the farthest area. And am I missing anything? The extensor pollicis brevis also attaches to the PIP. And yeah, I don't think these muscles are really high yield. And if they ask you on it, it'll probably be like a identifying type question. I couldn't find any cadavers provided for these deep extensor muscles, but just go over them in case. Here are the functions of them. So there's also the supinator, which kind of supinates the arm. It's in the name. It's present on the superficial head of the ulnar bone, or the radius, sorry. And yeah, they all basically do, the same function apart from the abductor pollicis longus, which kind of abducts the thumb, and the indices extends the second finger, or the index finger. Now for the neurovasculature of the forearm. So briefly speaking, right, the median nerve, which is right here, kind of supplies the majority of the flexors of the forearm, and it goes through the forearm and then gives off to the branch, being the anterior interosseous. This is the anterior interosseous right here, which supplies another compartment, or like also supplies the flexors of the forearm, but just different flexors. And the median nerve also continues as it was and supplies all the muscles too. The ulnar nerve comes from the side and then supplies, it supplies a couple of flexors in the arm, like the flexor digitorum profundus and the flexor carpi ulnaris. The radial artery, let's look at the blood supply now. Now, the brachial artery is accompanying the median nerve and goes here. Now, at this area, it divides into two arteries. It divides into the radial artery, and it also divides, let me rub this out, and it also divides into the ulnar artery right here, okay? Now, the ulnar artery will continue with the ulnar nerve, and it will supply the superficial palmar arch, or give off to the superficial palmar arch, which is this blood supply right here, and it supplies the whole palm of the hand, which is very important to remember. Now, the radial artery kind of goes behind, supplies the extensors or whatever, everything on the back, and gives off to another palmar arch, being the deep palmar arch, which is kind of present, more deeply, as it's in the name. And the radial nerve is nowhere to be seen, right? So let's get into like how the radial nerve looks. Now, the radial nerve, as we said, one of its branches, being the superficial radial nerve, goes through the cubital fossa, right? It's the S out of the MBBS. And this superficial radial nerve would supply like the skin of the forearm and stuff. But where does it divide though? If there's a superficial branch, that means there must be a deep branch, right? Now, the deep branch continues on the back. Once they've divided, deep branch kind of goes from the back. And then once it passes through a muscle known as the supinator, it divides further into two branches. It divides into the posterior interosseous nerve and then another branch in the back. And it supplies, as we said, or as when we were talking about the extensors, a lot of them were supplied by this posterior interosseous nerve. And it kind of branches off once it pierces the supinator muscle. So it could be important info to remember. Now for histology, discussed about anatomy. I know I've talked a lot, but anatomy for this block or for this OSPE will mainly be looking at lots of pictures and lots of cadavers and trying to, orient yourselves and the structures that are around it to kind of get, a better understanding or, make sure you guess them right or get them right. Now, histology is pretty much more easy. Hopefully we won't take too much time going through it. Firstly, we'll be talking about the skeletal muscle. Now, the skeletal muscle has three different layers: the epimysium, the perimysium, and the endomysium. Seen right here, the epimysium is the most outer layer, the perimysium is in the middle, and the endomysium is the inner layer, and kind of the cells from the inside. Now, for the histological features that you guys should remember. The skeletal muscle have peripheral nuclei. So what does this mean exactly? Now, the nuclei of the skeletal muscle, they're kind of pushed out to the side, as you can see, like right here. I don't want to cover them, right here. They kind of push to the outskirts of the skeletal muscle. They're not on the inside, right, or in the middle. Whilst they also have fibroblastic nuclei, which is also an important histological feature. Now, these fibroblastic nuclei, they are basically outcasts. They're pushed to the outside, the outskirts of the whole skeletal muscle, and they could be seen here. There's a bunch of them, and they are also an important histological feature that you guys should remember in the OSPE. At the inner, like we could see like the peripheral nuclei of the skeletal muscle and the fibroblastic nuclei, which are pushed to the outside. Okay, let's move on. There are also two types of muscle fibers that you guys should know: type 1 muscle fibers and type 2 muscle fibers. And the type 1 muscle fibers are known to be darker. The reason why they're darker is because they have a higher concentration of myoglobulin and a lower concentration of glycogen. As you can see here, these are the type 1 muscle fibers, and they're really dark compared to the type 2 muscle fibers right here. which are really light. And the reason why they're light is because they have a low concentration of myoglobin, which makes it darker, but they have low concentration of it. That's why that's light. That's why they are lighter. And they also have a high concentration of glycogen, which makes anything lighter. Okay, so just remember how they look: like type 2 lighter, type 1 darker. Now there's 3 types of cartilage: fibrocartilage, elastic cartilage, and hyaline cartilage. You'll be getting into them separately and looking at what makes them special, how you can identify them. Now, first thing you can appreciate with hyaline cartilage is that it's purple. It's really beautiful, right? I like the color, in my opinion. And it's made up of collagen type 2, or it's composed of collagen type 2 mainly. It's present in the trachea, if you guys remember from CVP. And they have 2 types of cells. They've got chondroblasts and chondrocytes. Now let's look at where these cells are exactly present. So the chondroblasts are kind of present right here, present right here. They're present sorry for this. My bad, guys. Again, yeah. So the chondroblasts are present on the side right here, okay? And the chondrocytes in this image, they're present in the middle. They're present inside of the lacuna. Okay, so whenever they if they label an area in the hyaline cartilage, firstly they'll probably say what type of cartilage this is. You say hyaline, and they'll be name the cell that the pointer is on. And if it's in the middle, it's probably the chondrocytes. If it's in the lacuna, it's the chondrocytes. If it's in the outskirts of the whole hyaline cartilage, then it's probably the chondroblast. An important thing you guys also should remember is that there is a perichondrium, and this perichondrium has 2 different layers. It has the cellular layer, which is the more inner one right here, and it has the fibril layer, or the fibrous layer, which is present more outer, more externally. That's about it for the features of the hyaline cartilage. And the main, it's very identifiable. It's purple. It's beautiful compared to the other cartilage that we'll be talking about right now. Now for the elastic cartilage, let's point out the obvious. It's not as beautiful as hyaline cartilage. It's pretty blue. It's present in the epiglottis, and it has 2 types of cells. It has chondroblasts and chondrocytes. Same thing. The chondroblasts again are present on the outskirts, whilst the chondrocytes are present inside the lacuna. So they're present more inly or internally. Now they also have 2 layers of the perichondrium. They have the cellular layer and the fibril layer on top of it. And they also contain elastic fibers right here, like these blue stuff, they're elastic fibers. And it's in the name, right? Elastic cartilage. So these are the elastic fibers, which are weirdly shaped. Let's move on. And they also contain type 2 cartilage. Now for the fibro cartilage. A fibro cartilage, to point out the obvious, it's pink and I don't think it's blue. I might be colorblind, but it has 2 types of collagen though, that it's composed of collagen type 1, collagen type 2. It's present in intervertebral discs. It has chondrocytes, which are, mainly on the slides that they have provided you with. They are present in the middle again. And its perichondrium has 2 different layers, the cellular layer, the fibrous layer, the cellular layer being more outside and the fibrous layer being more, or the fibrous layer being more outside and cellular layer being more inside. It's not present on the slide, but it will be present in other slides that you'll look at. Now for the bone, there are 2 types of bone we'll be getting into, the compact bone and the trabecular bone. Now the compact bone has periosteum, which is basically the outer layer of the bone, and it's composed of an inner cellular layer again and a fibrous layer. Now, histological structures that you guys should know in the compact or the cortical bone is, let's zoom in the image first. So we have these weird spirals right here. Sorry. They are known as concentric lamellae. They're known as concentric lamellae. And as a whole, with the small hole inside of it, it's known as an osteon. Okay, so this whole thing is an osteon. And inside of this osteon, there is a hole. This hole is called the Haversian canal, and it allows small blood vessels to kind of go through it and then supply the bone. What we also can appreciate is this weird structure right here. It kind of looks like a lollipop, okay? And it is called the Volkmann canal, okay? And we also have these lacuna, which are in the middle, which contain the osteocytes or the chondrocytes, sorry, and the PIS being the parallel lacuna, kind of present parallelly. So we got concentric lamellae and we got concentric and parallel lamellae. Let's move on. Now for the trabecular bone, one thing we can identify, it doesn't have osteon. So it doesn't have like the circular things that we looked at with the bone previously. And what it does have though, it has trabecula, which are these stuff right here, as trabecula, and it has a bunch of bone marrow in the middle. So this is bone marrow, this is trabecula, and it looks really different compared to the last bone, the compact bone. Now, it has two types of cells. No, it has three types of cells, sorry. It has the osteoclasts, which are present, or the osteocytes, sorry, which are present in the middle. They're present inside of the lacuna, again, just like the chondrocytes. And we have the osteoblasts, which are present on the outer skirts, which kind of look irregular because they're still developing. We've got the OCL, which are the osteoclasts right here. They're really big. They are multinucleated. And they kind of head toward this zone called the Howe-shaped lacuna, which is where bone resorption happens. So bone resorption being like the breakdown of bone. It's when all of these osteoclasts go to this area, kind of break down the bone and get to work. So osteoblasts, again, on the outside, they're developing. The osteocytes are in the middle of the lacuna. The Howe-shaped lacuna is responsible for for bone resorption, sorry, and a bunch of osteoclasts go towards it in order to do that. Now that is it for my section of this OSPE crash course. I hope I helped you guys. Hopefully you guys do amazing on the exam. I know you guys got this. And then after this exam, you can go back to, sleeping 14 hours per day in the summer. And inshallah, you all do amazing. Bitawfiq lakum. Assalam.
Okay, hi again. So I'll be taking over the lower limbs and the histology of the skin and the bones. So let's start off the endochondrial ossification. In the endochondrial ossification, we have 5 zones. We have the reserved cartilage zone, is when we don't have any matrices being done. We have the zone of proliferation. As you can see here, we have the cartilage is proliferating, and you can see here there's more than one cartilage. And then we have the third zone, which is the zone of hypertrophy. In the zone of hypertrophy, we can see much clearer cells than in the zone of proliferation. And then when we go into the fourth zone, we have the zone of calcification. And then lastly, we have the zone of resorption. So this is another image. This is when you go deep into the bone. Here you can see the osteoblast forming bone, and then you have secreting osteocytes. You have osteocytes here, and then in the middle you have the calcification. Intramembranous ossification. Here, the osteoblast is surrounding the piece of bone. As you can see here, we have osteoblast surrounding the bone. And then the central part is the mineralized bone, which is much more darker. As you can see, this is a lighter pink, and this is a much darker color. Then we have the osteoid, which is a brighter pink area. Where we have the fiber cartilage without any minerals. Once the minerals are added, it becomes mature bone matrix. The osteoblasts become entrapped to become osteocytes. So first, osteoblast will form osteocytes. First, we have osteoblast on the edges, and then we have the osteocytes in the middle. The parathyroid gland. Here in the parathyroid gland, we have 2 types of cells. We have the chief cells, which are the darker purple color cells. And then we have the oxival cells, which is the pinkish color. The chief cell is the one that's responsible for secreting the parathyroid hormone. And the oxival cell is much more, it has a supporting role. Then you can see here, we have the adipocytes and the lipid circles. That's it for the parathyroid gland. Then we'll go over the skin. In the skin, we have the thin skin. So we have thin skin and we have thick skin. In the thin skin, we have 4 layers. Stratum basale is the first one. Then we have stratum spinosum. Then we have stratum granulosum. So stratum basale is the one in the first one. Okay. Then above it, we have the stratum spinosum. Then we have the stratum corneum. This is this one, the darker color one, and then we have lastly the stratum corneum. So in the stratum basale, we have three cells. It contains three types of cells. It contains stem cells, and then it contains melanocytes, which are the darkly colored one, and then the Merkel cells, which are sensory cells. Then we have the stratum spinosum. Here we have the stratum spinosum. It has a spiny appearance due to the desmosome. I'll show you. It's like spiny appearance. You can see, it's like a bit of a diamond shape due to the desmosomes between the keratinocytes. Okay, and then its role is to provide the structural support to the skin. It contains, as I said, keratinocytes and Langerhans cells. Langerhans cells are like immune cells in the skin. Sorry. Then we have the stratum granulosum, where it consists of a flattened keratinocytes that are thin, darkly stained line. So it forms a thin, darkly straight line, as you can see. And it contains keratinocytes. Lastly, we have the stratum corneum, composed of multiple layers of keratinized cells or dead cells, which are called corneocytes. These cells are continuously shed in a process called desquamation. So you can see these are the stratum corneum layer. Now the thick skin. So what is the difference between the thin and the thick skin? The thick skin has the same layers, stratum basale, stratum spinosum, stratum granulosum, and then we have corneum, stratum corneum, but lastly it has stratum lucidum. That's the difference between thick skin and thin skin. You can see the thick stratum lucidum here. The pilosebaceous gland. The pilosebaceous gland contains three things. Pilo for the erectile pili muscle here, as you can see them, skeletal muscles, and then we have the hair follicle. This is the hair follicle, and then the sebaceous gland. You can see these are the sebaceous glands. So it's like it's a unit of a hair follicle, the erectile pili muscle, and the sebaceous gland. This is another picture of what a hair follicle would look like with. This is a hair follicle. Another picture of a hair follicle. You can see this is the hair follicle. You can see these are the glands, and this is the erector pili muscle. Oh, now we'll go over the sweat glands. So we have two types of sweat glands. We have apocrine glands and eccrine glands. Apocrine gland is a simple cuboidal to columnar cells. You can see they are cuboidal, but sometimes it may look columnar or cuboidal. It is surrounded by myoepithelial cells. I don't think you can see the myoepithelial cells here. It is larger, wider, and less numerous than the eccrine gland. So when you want to compare it to the eccrine gland, as you can see here, and this is the eccrine gland. So you can see, it's smaller, and the lumen is small. So it's not wide, it's small, and the lumen is small. Here, the difference, it's so wide, and the lumen is wider, and it's larger. It is apocrine gland, unlike eccrine gland, is associated with hair follicles. It creates odor sweat that is high in protein, and it is a perfect environment for bacteria. It gets activated in the puberty. So unlike eccrine gland, apocrine gland gets activated in puberty. Now let's go over the eccrine gland. So as we said, eccrine gland is much smaller. The lumen is wider, and you can see here it is simple columnar, simple cuboidal, as the same as apocrine gland. And myoepithelial cells surrounding we have myoepithelial cells surrounding the acines. I don't know if yes, I think these can be myoepithelial cells. They're not as clear. We consider them myoepithelial cells. They secrete, unlike the apocrine gland, they secrete clear, odorless fluid. So not odor fluid, odorless fluid composed of water and electrolytes. So this is another picture of the eccrine gland. As you can see, they're cuboidal in cells. The lumen is small. And one thing about eccrine gland, so we have the eccrine gland, the acinin, and then we have the duct in the dermis. And then in the epidermis, we have something called the acrosynergium. which is the duct that opens into the environment and secretes the fluid. Now we'll go over the mesenteric corpuscle. The mesenteric corpuscle is found in the dermal papilla, and it is found in the thick skin of the fingertips. It is rapidly adapting mechanoreceptor. You can see here we have this is the mesenteric corpuscle. This is another picture of the pecan corpuscle. You can see it's in the dermis, and the pecan corpuscle is in the reticular dermis. Dermal papilla, and dermal papilla is where we can find the mesenteric corpuscle. I think they ask about this a lot. It is where we have the mesenteric corpuscle. Where is it found? In the dermal papilla. Where is the pecan corpuscle found? In the reticular dermis. So here is the pecan corpuscle, which is found in the reticular dermis, thick skin. So it's found in the thick skin of the fingertips, and it responds to coarse touch. Another picture, this is the pecan corpuscle, and this is the mesenteric corpuscle found in the papillar dermis. Now we will be starting our anatomy part, where we're going to talk about the lower limbs. So we'll be starting with the gluteal region. Before we start with the gluteal region, we want to identify the hip joint, or the hip bone. The hip joint is composed of a ball and a socket joint. This ball and socket joint, the ball will be the acetibulum, the socket will be the acetibulum, and the ball will be the femoral head. They will bind together to form a ball and socket joint. This ball and socket joint is a type of synovial joint that allows certain types of movement, such as abduction, adduction, deflection and extension, lateral rotation and medial rotation, and circumduction. So we'll talk about the hip bone now. The hip bone is composed of three parts: the ilium, which is the largest part, the pubis, and the ischium. Okay, the pubis is more anteriorly, the ischium is more posteriorly. Then we have the striate cartilage, which links these three types of muscle together to form the acetibulum. Three types of bone linking. So we'll dive more into the hip bone. The hip bone, I mean. So this is the iliac crest. So we have the iliac crest here, the iliac fossa, and then we have here the posterior inferior iliac spine. So this is the anterior superior iliac spine, so it's superior. This is the anterior inferior iliac spine. This is the posterior superior iliac spine, and the posterior inferior iliac spine. Then we have the ischial bone and the obturator foramen. Then here we have the acetibulum. Then we have the pubic tubercle, the superior ramus. So this is superior ramus, and then pubic tubercle. Under the pubic tubercle is the inferior pubic ramus. Above the pubic tubercle, we have the superior pubic ramus, and then we have in the ischial tuberosity, we have the ischial ramus and the ischiopubic ramus. It connects the ischium to the pubic bone. So the ligaments of the hip bone. What are the ligaments of the hip bone? So we have 4 ligaments. We have the iliolumbar ligament. So it goes from the ilium bone to the lumbar bone. And then we have the posterior sacroiliac ligament. So it's posteriorly located from the sacrum. Here, this is the sacrum to the ilium. We have the sacrospinous ligament here from the spine into the sacrum. We have the sacrotuberous ligament from the sacrum into the tuberous, or the ischial tuberosity. So now we finished from the hip bone. We're gonna go into the femoral bone, or the femur, in other words. So the femur, we have the head. This is the head, the neck, and the shaft. Okay. So we have the head. The head contains the fovea captus, which is for the attachment of the ligamentum teres. Then we have the neck, which is a common site for fractures. The neck, we'll be talking about the fractures concerning the neck. We have this here, which is the intertrochanteric line. So how can we know that this is the intertrochanteric line or intertrochanteric crest? So the difference is the intertrochanteric line will be smooth on touch, and the intertrochanteric crest will be, it's anteriorly. So how can you know if it's anterior? If you're holding the femur is anteriorly placed or posteriorly placed, you look for the intertrochanteric line, which is located anteriorly. It's a smooth line. And then we have the intertrochanteric crest here. the neck of the femur, the head of the femur, and then here we have the fovea capitis. Then we have the lesser trochanter and the greater trochanter. The greater trochanter is more superiorly, and the lesser trochanter is more inferiorly. And then on the distal end, we have the lateral femoral condyle and medial femoral condyle. So this is the lateral side, and this is the medial side. We have the condylar fossa. Then we have something called the linea aspera, which is kind of a groove or a groove made by the muscles. So the proximal end, it contains, as we said, the head, the neck, the lesser trochanter, which is a posterior, which has a posterior medial projection, posteriorly and medially project, and it is used for attachment it is an attachment for the iliopsoas muscle. The greater trochanter, which has a lateral projection, and it is an attachment for the gluteus medius and minimus. The intertrochanteric line, as I said, it is anteriorly placed and marks the transition between the neck and the shaft. So here we have the neck, here we have the shaft. What marks the transition? The intertrochanteric line. Then we have the intertrochanteric crest, which is posteriorly placed, and it's like more of a curved. It has a curved shape. Then we have the shaft. So this is the shaft. In the shaft, we have something called the linea aspera, which is a prominent longitudinal ridge on the posterior surface. So this is the posterior surface where we have the intertrochanteric crest. The distal end, we have the medial and the lateral condyle. So this is the medial lateral condyle, medial and lateral epicondyles. These are so this is the condyle. These are the epicondyle. You can see here. I want to show you. This is the epicondyle, and this is the medial, the condyle. That's the difference between epicondyle and the condyle. And then we have the intercondylar fossa. So between each condyle, we have the intercondylar fossa and the patellar surface, which is this one here. The blood supply. So the blood supply for the So what is the blood supply for the hip bone or the femur? The femur in the femur. What is the blood supply for the femur? We have the medial circumflex artery, the lateral circumflex artery, and the artery to the head of the femur. The medial circumflex artery will supply the neck of the femur. The lateral circumflex artery will supply the anterior part of the neck and the greater trochanter. So it will supply the anterior part of the neck where we have the intertrochanteric line and the greater trochanter, and then the head of the artery to the head of the femur. From its name, it's a branch of the obturator artery to the head of the femur. So this is an image. So we have here the medial circumflex artery will supply the neck, and then we have the the lateral circumflex artery supplying the greater trochanter and the intertrochanter. And then we have, these are the retinacular arteries, superior and anterior, posterior, inferior. That's also a branch of the medial circumflex artery that supplies the neck of the femur. And we have the artery of the ligamentum teres, or the artery to the head of the femur. Here it is. So the blood supply. So we talked about the blood supply to the neck, to the head of the femur, or the proximal femur. Now we can talk about the blood supply of the distal femur. So what supplies the distal femur? We have the deep femoral artery, giving us the femoral artery, which supplies the distal femur, and it will go into the adductor hiatus and continue, and then give us the popliteal artery. We'll emphasize on it later on. The femoral neck fracture. So I told you that we're going to talk about the neck fracture. So here, the femoral neck fracture is really dangerous, actually. So in the femoral neck fracture, you can see the femur is fractured here, and here you can see it's fractured. So in the femoral neck fracture, what artery will be damaged? It will damage the medial circumflex artery, which can lead to necrosis of the neck or the head of the femur, and this will require replacement of the head of the femur the femur, all of it, the head of the femur. So the femoral fracture, as I said, medial circumflex femoral artery is at risk of rupture. If it's ruptured, it will lead to necrosis of the femoral head. Femoral neck fracture most commonly happen in the posterior and postmenopausal women because of osteoporosis. This is another type of fracture, which is intertrochanteric fracture, that a fracture in the intertrochanteric line that damages both medial and lateral circumflex artery. Now we'll be talking about the ligaments of the hip joint. So in the hip joints, we have 4 ligaments. We have the inferior the 4 ligaments. The iliofemoral ligament, which goes from the ilium bone to the femoral bone, attaches on the greater trochanter and the greater trochanter here. And then we have the pubofemoral ligament goes from the pubis, okay, to the femur. This is anterior view. And then we have the ischiofemoral ligament going from the ischium backward, posterior view, to the femoral bone. Then we have the this is the same, the iliofemoral bone, but from the posterior view. So we have 4, as I said, the iliofemoral from the ilium to the femur, the pubofemoral from the pubis to the femur, the ischio, and we have 3 actually. The ischiofemoral from the ischium to the femur. The gluteal muscles. Now we'll go into the gluteal muscles. So in the gluteal muscle, we have superficial muscles and deep muscles. So superficial muscles, we have the gluteus maximus, gluteus medius, gluteus minimus, and tensor fasciolata. We'll start off with the gluteus maximus. The gluteus maximus will originate from the posterior gluteal line. As you can see, this is the posterior gluteal line here. I can't draw clearly, but this is the posterior gluteal line. And then it in the ilium and inserts into the ilio. So it has two insertions. One in the iliotibial tract, and the other one it inserts into the gluteal tuberosity of the femur. This is another picture where we have the gluteus maximus inserting into the greater trochanteric of the femur, or the tuberosity, and then it inserts another insertion into the tensor fasciolata, or the iliotibial tract. So what are the functions of what is the gluteus maximus? What is its role? What is its significance? So the functions of the gluteus maximus is to extend the hip joint. So its main function is to extend the hip joint. It also stabilizes the knee joint laterally and tenses the fascia lata through the iliotibial tract. So as we saw here, so this is the gluteus maximus, and then this is the tensor fasciolata. This is and they will join together to form the iliotibial tract. So it will tense the fasciolata through the iliotibial tract. It laterally rotates and it laterally rotates the thigh. So it stabilizes the knee joint laterally and tenses the fasciolata through the iliotibial tract and laterally rotates the thigh. So what do you mean by extension of the hip joint? Extension of the hip joint, we can see this action when we are climbing the stairs. So if you had a scenario where the patient cannot or is unable to climb the stair, or to walk in the stair, or is unable to stand from a sitting position, he has dysfunction in the gluteus maximus. You can see it also functions in the flexion of the hip joint and extends so you can see it's extending the hip joint when you are climbing the stair, and when you're standing from a sitting position, it acts in flexion of the hip joint. It is innervated also by the inferior gluteal nerve. The gluteus medius originates between the anterior and posterior gluteal line. So this is anterior, and this is the anterior gluteal line. So it originates from the anterior gluteal line and inserts into the greater trochanter of the femur. It abducts. So what is its role? It abducts and medially rotates the leg. So it abducts the leg and medially rotates it. This is another picture. You can see this is the gluteus medius on the cadaver. This is the gluteus maximus. And you can see these are the blood supply of the gluteus maximus. So this is the gluteus medius, okay? Gluteus maximus. This is the piriformis, the obturator, and I'll come back to these muscles later. Gluteal minimus originates between the anterior and inferior gluteal line. So this is the gluteal medius. So this is the anterior line, this is the inferior line. So it originates between the anterior and inferior line, gluteal lines on the hip. It inserts into the lateral side of the greater tubercle. So it inserts into the lateral side of the greater tubercle and has the same function as the gluteus medius, which is abduction and medial rotation of the leg. So gluteus medius and minimus have the same function, which is abduction and medial rotation of the leg. So what is Trendelenburg sign? Here in Trendelenburg sign, we have both the gluteus medius and minimus maintain the pelvis level of the opposite side of the stepping leg. What do I mean? So in this picture, you can see here this patient, this person is stepping, and you can see in normal gluteus medius and minimus, the pelvis is maintained straight. But when we have dysfunction of this muscle, it's gonna drop. So the opposite pelvis will drop. So this is what we call by Trendelenburg sign, where the opposite side of the opposite side of the pelvis, the opposite pelvis side will drop when you're stepping. So if there was a damage to the superior gluteal nerve, so this superior gluteal nerve which innervates the medial gluteus medius and minimus, there will be loss of function, which is maintaining the pelvis position of the opposite side, maintaining its position. So a positive Trendelenburg sign is when the pelvis of the opposite side, as I said, drops when the opposite leg is stepping. Tensor fascial latae. So we talked a lot about tensor fascial latae. Tensor fascial latae inserts into the iliotibial tract, as I showed you in the picture, in the previous picture. It stabilizes the knee joint laterally. So what does it do? It stabilizes the knee joint laterally and tenses the fascia latae through the iliotibial tract. So it tenses the fascia latae through the iliotibial tract. So the fascia latae is tensed through the iliotibial tract. What is the iliotibial tract? Iliotibial tract is a thickening of the fascia latae, and it inserts into the lateral side of the tibia. So this is the iliotibial tract. You can see this is the tensor fascial latae, and you can see this is the iliotibial tract. I don't think it's that clear, but I didn't have any other images for the cadavers. Now we'll be talking about the lateral rotators of the hip, or in another word, the deep muscles of the gluteal region, which are the piriformis, inferior gemellus, the quadratus, superior gemellus, and obturator internus. So the piriformis, what is the function of the piriformis? Piriformis functions in lateral rotation of the extended hip and abduction of the flexed hip. So it laterally rotates the extended hip and abducts the flexed hip. It originates from the sacrum, as you can see here, and reaches the gluteal region through the greater sciatic foramen. So it originates from the sacrum and reaches the gluteal region, and through the greater sciatic foramen, it inserts into the superior aspect of the greater trochanter. Innervation, it is innervated by S1, S2 nerve. So what are the innervations of the piriformis? Innervated by S1, S2 nerve. What are the clinical significance of the piriformis? So piriformis muscle can cause something called piriformis syndrome, where we have the piriformis muscle will, as we said, it exits through the greater sciatic foramen. So it might press on the sciatic nerve, causing piriformis syndrome. This is common in cyclist athletes, and the pain is released from the sciatic nerve. Compression is called sciatica. So when you see a person sciatica or he has pain and he is a cyclist, this is piriformis syndrome. There is going to be a hypertrophy of the piriformis that will press on the sciatic nerve and cause something called sciatica. Obturator internus is associated with lateral rotation of the extended hip. So it laterally rotates the extended hip. It abducts the flexed hip. So it the same as They all have the same functions, or the lateral rotators. So what do? They lateral rotate the extended hip and abduct the flexed hip. It originates from the interior side, so the inferior side of the obturator foramen, and exits through the lesser sciatic foramen. So this is the greater sciatic foramen, which through which the piriformis muscle exits through, and this is the lesser sciatic foramen, where the obturator internus exits through and attaches to the, as we said, the greater tuberous. Superior gemellus and inferior gemellus, they both insert into the medial side of the greater trochanter, but superior gemellus inserts above the obturator foramen. So here we have the obturator internus muscle. Okay, so how can we locate it? We have here the gluteus minimus. Then we have the piriformis exiting through the greater sciatic foramen. Then we have the obturator internus, as we talked about. Above the obturator internus, you're gonna find the superior gemellus, and below the obturator internus, you're gonna find the inferior gemellus. So the obturator internus is it's like a sandwich. Obturator internus is like a burger, and the superior gemellus is the top bread, and the inferior gemellus is the bottom bread. It's like the superior gemellus is superiorly bounded by it, and the inferior gemellus is below the obturator internus. The quadratus femoris inserts into the intertrochanteric crest. So it goes from here and enters into the intertrochanteric, as we said, this is the intertrochanteric crest. It's more of a curved shape. And you can see this is the posterior view. Now we'll go over the blood supply of the gluteal region. So we talked about the muscles, we talked about the innervations, the functions. Now we'll be talking about the blood supply. So in the blood supply, we have three arteries that supply the gluteal region. We have the superior gluteal artery, the inferior gluteal artery, and the profunda femoris. The superior gluteal artery, which muscle is it gonna innervate? It's gonna innervate the gluteus medius, and gluteus minimus. The inferior gluteal artery will innervate the gluteus maximus, and the profunda femoris will give arteries will form the medial and lateral circumfemoral artery, which are going to supply the neck of the femur. So again, superior gemellus will supply both gluteus medius and minimus. Inferior gluteal, will supply the gluteus maximus, and superior gluteal the gluteus medius and minimus. This is a picture of where do they look, or how do they look on a picture. Here we have the piriformis. So take the piriformis as a landmark. Above the piriformis, you're gonna see the superior gluteal artery. Below the piriformis, you're gonna see the inferior gluteal artery. And here you can see the profunda femoris will give the medial circumflex here, and which will supply the neck and the head of the femur. The nerve supply of the gluteal region. Here we have two nerves that supply the gluteal region. We have the inferior gluteal nerve, which supplies the gluteus maximus, and we have the superior gluteal nerve, which supplies the gluteus medius and the gluteus minimus. So again, the same as the arteries. Inferior for gluteus maximus, superior for both medius and minimus. Okay, so I'm gonna be talking now about the thigh muscles. Okay, so in the thigh muscles, we have three compartments. We have the anterior compartment, posterior compartment, and medial compartment. So we'll be talking about the anterior compartment first. So the anterior compartment, we have four muscles: the rectus femoris, vastus medialis, vastus lateralis, the vastus, and vastus intermedius. So here we can see this is also we have the sartorius. So this is the sartorius. This is the rectus femoris, the vastus medialis. You can see this is the medial part, and then vastus lateralis, and vastus intermedius is more deep. You can't see it. And we have here the pectineus. Vastus intermedius is more deep. It is below the rectus femoris. So so what is the function of the quadriceps femoris? The function of the quadriceps femoris is to extend the knee, except for the rectus femoris, which has an additional function, such as which is flexing the knee, flexion of the knee. So it does flexion of the knee and of the hip. Flexion of the hip and extension of the knee. So again, quadriceps femoris, we have four muscles: rectus femoris, vastus medialis, so rectus femoris, vastus medialis, vastus lateralis, the and then and vastus intermedius below behind the rectus femoris. And the nerve supply for the anterior compartment is the femoral nerve. The medial compartment, we have the adductor. The adductors they are called the adductors of the thigh, which are, we have here the obturator externus, the adductor brevis, the adductor longus, and adductor magnus. They are innervated by the obturator nerve, except for the tibial part, of the adductor magnus, which is innervated by the tibial division of the sciatic nerve. The medial compartment, so in the medial compartment, we have something called the adductor hiatus, which is located at the end of the adductor magnus tendon. So the adductor hiatus here is located at the end of the adductor magnus tendon. So this is the adductor magnus. Here we have the adductor hiatus. It is an opening for the femoral artery to reach the popliteal fossa. So it is an opening for that is used for the femoral artery to reach the popliteal fossa. So you can see here, this is the adductor hiatus. You can see it. This is here the adductor hiatus at the end of the tendon for the adductus magnus. The adductor hiatus. So what are the boundaries for the adductor hiatus? We have anterior laterally, it is bounded by the vastus medialis. So anterior laterally, it's bounded by the vastus medialis. Posteriorly, it is bounded by the adductor longus and magnus. So you can see the adductor longus and magnus posteriorly here. And then medially, it is bounded by sartorius, which forms the roof of the canal. So sartorius forms the roof. I don't think you can see it in this image. I think the next image is much more here. So you can see here, we have, this is the adductor hiatus, okay? At the end of the tendon for the adductus magnus. The sartorius makes the medial border. Then we have which also the floor, and then we have the adductus magnus and longus makes the posterior border, and the anterior and lateral borders is bordered are by the vastus medialis. The contents of the adductor hiatus are the femoral artery and vein, the saphenous nerve, and the nerve to the vastus medialis. This is a cadaver to show you here. This is the patella. Okay, so you can see the patella here. You can see this is the rectus femoris. This is the rectus femoris. You can see it's touching here anteriorly. Then we have on the lateral side vastus lateralis from its name. On the medial side, we have the vastus medialis. You can see this is the sartorius. It's going to attach here. And then we have the tensor fasciolati on this side. And then behind the rectus femoris, I think this would be the vastus intermedius. Another picture, you can see here, this is for the adductors. This is the adductor longus. This is the adductor magnus. It's more deep. And this we have here the gracilis muscle. This is the medial side. So you can see this is the patella, this is the medial side. This is sartorius here. You can see it attaches, it goes and inserts into the lower knee or the lower patella. So the femoral triangle, so we have the adductors here, and then we have the femoral triangle. The femoral triangle have three borders. We have the superior border by the inguinal ligament, the lateral border by the sartorius, and the medial border by the adductor longus. The floor is made by two muscles, the iliopsoas laterally, and the medially we have the pectineus. So medially we have the pectineus horn here. You can see this is the pectineus, I think. And then we have laterally we have the iliopsoas. Again, the borders are superiorly we have the inguinal ligament, laterally we have the sartorius, medially we have the adductor longus, and the floor is made by two muscles, iliopsoas and pectineus. Contents of the femoral triangle. So femoral triangle, you can use this mnemonic, which is navel. That stands for, we have from laterally to medially. Laterally where we have the sartorius, medially where we have the adductor longus. Laterally, we're gonna start with the femoral nerve. then we have the femoral artery, femoral vein, then we have the deep lymph nodes. So femoral nerve, femoral artery, femoral nerve, the canal, the femoral canal. I don't think it's here. And then we have the deep lymph nodes. This is this is on the cadaver. You can see this is the sartorius, which makes the lateral border, and then we have the adductor longus, which makes the medial border. Here you can see this is the vein. This is the femoral artery, femoral vein, and then you can see this is the pubic tubercle. As you can see, the iliopsoas, which makes the psoas major, which will combine with the iliac muscle to form the iliopsoas, which will form the floor of the femoral canal or femoral triangle. This is another picture to show you the pectineus muscle here and iliopsoas muscle. Now we'll go over the posterior compartment, which has the hamstring muscles. What are the hamstring muscles? We have the semitendinosus, semimembranosus, the biceps femoris, which has a short head and a long head. Okay, so we can see this is the short head from the ischium, and then we have this is long head. This is the short head. This is semimembranosus, semitendinosus, has a long tendon. So the hamstring muscles, what are the function of the hamstring muscles? They are used for they flex the knee joint. So they're used for flexion of the knee joint, okay? Wait, let's move this. Okay, so they're used for the flexion of the knee joint, extension of the hip, except for the biceps femoris. So they all extend the hip, except for biceps femoris does not extend the hip. So they all flex the knee, and they extend the hip, except for which muscle? The biceps femoris. They're innervated by the tibial division of the sciatic nerve, and the short head is innervated by the common fibular division of the sciatic nerve. So the short head has different innervation, which is the common fibular division of the sciatic nerve. Biceps femoris, as we said, biceps femoris has two heads, the long head and the short head. It is located laterally. It flexes the knee, as we said, laterally and rotates the hip. So it flexes the knee laterally and rotates the hip. It has two heads, as we said, long head and short head. The long head originates from the ischial tuberosity, as you can see here, as I showed you. So the long head from the ischial tuberosity, you can see here. And the short head originates from the femur. So as you can see here, we have the long head originates from the ischial tuberosity, you can see here, and the short head is originating from the femur. So this is on the cadaver. You can see this is the biceps femoris muscle, and you can see this is the medial tendon of the biceps femoris here. This is the long head originating from the ischial tuberosity, and this is the short head originating from the femoral nerve, femoral bone. Semimembranosus, what's the function of semimembranosus? It flexes the knee joint, contributes to the knee capsule, and attaches to the posterior aspect of the medial condyle of the tibia. So it flexes the knee joint, okay? It contributes to the knee capsule here. It attaches to the posterior aspect of the medial condyle. So we have here, this is the medial side. So when the medial side is more toward the midline of the body. So this is whenever you're confused, medial toward the midline of the body. So here we have the medial condyle. This is, as we said, these are the condyle, these are the epicondyle. So the medial condyle, so attached to the posterior aspect of the medial condyle of the tibia here. Medial condyle of the tibia. Then we have semitendinosus. Semitendinosus, it flexes the knee and it is located medially. So it flexes the knee located medially and has a long tendon, okay? So you can see this is, it originates from the ischial tuberosity, and here it's located medially and attached to the tibia. So what is now I'm saying they all attached to the ischial tuberosity. What is the function? What is the clinical significance? So if you have a case, in the case it's like damage to the ischial tuberosity, or they get you an X-ray where the ischium is damaged or broken, there will be dysfunction of the hamstring muscles, as not all of them except the biceps, the short head of the biceps femoris attached to the ischial tuberosity. So as you can see here on the cadaver, this is the semitendinosus with a long tendon, This is the difference between semitendinosis and membranosus on a cadaver. Semitendinosis, you know it from its long tendon. So you can see all of this is its tendon. Semimembranosus is more like a membranous. It's membranous and it's flat on the cadaver. And it is located medially. So you go and locate it. Is this medially located or laterally located? If it's medially located, semitendinosus. And long tendon, semitendinosus. This is biceps femoris. Okay, this is the long head. As you can see, it's coming from the ischium, ischial, and this is sciatic nerve. Between them, you can see this is the sciatic nerve. Now we finish from the thighs. What is the blood supply of the thighs? Okay, so we have three arteries. We have the femoral artery, the obturator artery, and the inferior gluteal artery. The femoral artery is a branch of the external iliac artery and supplies the anterior aspect of the thigh. Okay, which are the quadriceps femoris, the thoracic, and the pectineus muscles. These are the anterior compartment. The obturator artery is a branch of the internal iliac artery and supplies the medial compartment, which are the adductor muscles, adductor magnus, adductor brevis, adductor longus, and the medial compartment. And then we have the inferior gluteal artery, which is a branch of the internal iliac artery and supplies the posterior thigh and the gluteal artery. As we said, inferior artery supplies which muscle in the gluteal region? It supplies the gluteus maximus. So the inferior gluteus supplies the gluteus maximus and also supplies the posterior thigh muscle. So the nerve innervations. The nerve innervations, we have three nerves that innervate. We have the anterior compartment is innervated by the femoral nerve L2, L4. The medial compartment is innervated by the obturator nerve L2, L4, and the posterior compartment is innervated by sciatic nerve L3, S7. So we talked about the sciatic nerve. What is the sciatic nerve? Sciatic nerve will supply the hamstring muscles and at the popliteal fossa. So here we saw it on the cadaver. Here, it's going from the through the length of the femur into the popliteal fossa. So at the popliteal fossa, it will divide into two nerves. It will divide to give us the tibial nerve and the common fibular nerve, which will supply the leg muscles. Okay, so we finished from the thighs. Now we're going over the knee joints. In the knee joint, so what is the component of the knee joint? So here first we have the quadriceps tendon. It will go over and will join the patellar tendon, okay? And then we have here, this is the tibial collateral ligament, or in another word, the medial collateral ligament. Then we have this is the fibular collateral ligament, which is on the fibular side. So fibular and the tibia. This is the tibial collateral ligament, medial. So the tibia is medially, the fibula is located laterally. So it can be called lateral collateral ligament and medial collateral ligament. This is the fibula and this is the tibia, okay? This is another view. Here we see we have also other tendons, such as we have the anterior cruciate ligament here, and posteriorly here we have the posterior cruciate ligament. Here we have, this is the, as we said, fibula laterally located, lateral menisci, and this is the medial menisci. So we talked about the fibula and the tibia. This is the tibia bone. This is the tibial bone. Here we have the medial condyle medially, lateral condyle. This is the head of the fibula. This is the fibula, the fibular notch here, the lateral malleolus, the medial malleolus, and we have here the tibia. Injuries. So injuries, we have function of the ACL. It prevents. So if we have injury to the ACL, what will happen? So what is the function of the ACL in the first place? ACL, or the anterior cruciate ligament, prevents the tibia from moving anteriorly to the femur. So it prevents it from sliding anterior to the femur. It provides rotational stability to the knee. What will happen if we have ACL, or how can we have an ACL injury? ACL injury can be caused by hyperextension or a sudden stop. So you're running in a fast pace and then you suddenly stop. This can cause hyperextension, which will lead to an ACL torn. This is common in soccer players. So you see them running in a fast pace and then they stop or they fall. That can cause hyperextension of the knee and can lead to ACL injury. Then we have the posterior cruciate ligament, as we can see here. So if injury happens below the knee at the tibial tuberosity, the tibia is dislocated posteriorly. So the posterior cruciate ligament prevents the tibia from going posterior to the femur. Okay. So if we have hyperflexion, which hyperextension, hyperflexion of the hyperflexion of the knee, we can have the PCL injury, and this will lead to the tibia will be dislocated posterior to the femur. We have something called the unhappy triad syndrome, where we have a rupture of the medial collateral ligament, torn medial menisci, and rupture of the anterior cruciate ligament. So these are the three unhappy triad. Okay. This happens when we have a direct injury or direct force from this direction, from the lateral side, can lead to a damage of. So it will lead to you're gonna have a push or a forward force hitting the knee from lateral side, which will lead to a rupture of the medial collateral ligament and the ACL and the medial meniscus. It is caused by a forced abduction and external rotation of a semiflex knee. So it is semiflex, and you have a forced abduction and external rotation of the knee. So we're done with the. So now we're gonna go to the leg muscles. We have the posterior leg muscle, where we have the gastrocnemius, two heads of the gastrocnemius, so it has two heads. Then we have the plantaris beneath it, and then we have the soleus. All of these three muscles will contribute to the calcaneal tendon. So as you can see here, it's like a fish. So you can see it looks like a fish, the gastrocnemius. This is the medial head, this is the lateral head, the soleus, and between these two, we have the plantaris. So the soleus muscle, so the soleus is beneath the soleus muscle, we have something called the soleus hiatus. As we had the adductor hiatus, we have something called the soleus hiatus, where we have the popliteal vein and artery, and tibial nerve will pass through it. So what will pass through the soleus hiatus? The popliteal vein and artery and tibial nerve. This area is significant because in cases of compartment syndrome, where this patient has compartment syndrome. I don't know if you took it, guys, where you let's say you wrapped he had an injury and you wrapped the leg so tightly that he had the arteries and the veins are compressed, and you have a compartment syndrome. So gastrocnemius. So as we said, this is gastrocnemius. This is the plantaris between the gastrocnemius and the soleus, and this is the soleus muscle. This, at the end, the contribution of these three muscles will form the calcaneal tendon or the Achilles tendon. So we have in the posterior leg, we have superficial muscles. So the superficial muscles are the muscles that we said, the gastrocnemius, the soleus, and the plantaris. Then we have the deep muscles, which are the popliteus, the tibialis posterior, flexor digitorum longus, and flexor hallucis longus. Okay, so it starts from the medial side of the tibia. So the popliteus starts from the medial side. So this is the medial side. You can see starts from the medial side and goes to the lateral side of the feet. Okay, what is the function of the popliteus? So when it contracts, it will shrink and will pull it to this way, unlocking the knee. So its function is to unlock the knee. And the other deep muscles are tibialis posterior, flexor digitorum longus, and flexor hallucis longus. From its name, flexor digitorum longus, it flexes the four digits. Okay, except the big toe. Flexor hallucis longus flexes the hallucis, which is the big toe. And tibialis posterior is used for it functions in plantar flexion. All of these muscles are innervated by the tibial nerve. So what is the function of the posterior leg? As we said, gastrocnemius for plantar flexion of the ankle and flexion of the knee. Its function in powerful walking. So when you want to walk, run, or jump. Soleus, it causes plantar flexion of the ankle, and this is used for postural muscle for maintaining standing. So when you're standing for a long time, you're using soleus. Plantaris is it causes weak plantar flexion and knee flexion. The tibialis posterior is used. It causes inversion of the foot and weak plantar flexion. So it is used in inversion and weak plantar flexion. Its function. So a dysfunction in tibialis posterior, what will it cause? Flat foot. So if you have flat foot in the question, it's immediately tibialis posterior. Flexor digitorum longus, action of the flexor digitorum longus, as we said, flexor digitorum, so the digits, lateral foretoes. Flexor hallucis longus, flexus the big toes, the hallucis. Anterior leg, between the tibialis anterior and the extensor digitorum, we have deep peroneal nerve. So in the anterior leg, so we have here, we have the extensor hallucis longus, and then we have the extensor digitorum longus. So here we have, this is the extensor hallucis longus. You can see it's going to the big toe. And this is the extensor digitorum. You can see it's going to the other digits. And then we have another muscle, which is the tibialis anterior. All of these are innervated by the deep peroneal nerve. So the anterior leg is innervated by the deep peroneal nerve. The posterior leg is innervated by the tibial nerve. This is another picture for the anterior compartment. Here you can see this is the tibialis anterior, okay? This is the extensor hallucis longus going to the big toe, and this is the extensor digitorum longus. You can see this is the, you can see it's going to the other digits here. So whenever you want to identify which muscle is this, just track it to where it ends. So you can see where does it end. So if it ends in the at the big toe, it's extensor hallucis longus. If it ends on the other toe, it's the other toes, it's extensor digitorum longus. The lateral leg consists of two muscles: the fibularis brevis and fibularis longus. Fibularis longus is the long one. Fibularis brevis is the short one. So you can see this is fibularis longus coming from here from up. And this is fibularis longus coming from the tibia, or the fibula, I mean. So we have fibularis longus, as I said, and fibularis brevis. Fibularis longus, the origin, it comes from the head and the upper lateral shaft of the fibula. Okay, it inserts into the base of the first metatarsal and medial cuneiform. It everts and plantar flexes the foot. So it everts and plantar flexes the foot, supports the transverse arch of the foot. Fibularis brevis origin is at the lower, it originates from the lower lateral shaft of the fibula. So as you can see, this originates from the upper shaft. This originates from the lower shaft. That's why its head is small. This is the small one. This is the long one. And inserts into, so the fibularis longus inserts in the first metatarsal. Fibularis brevis inserts into the tuberosity of the fifth metatarsal. And they both avert the foot and are assessed in plantar flexion. And both of them are innervated by superficial fibular. So superficial fibular innervates lateral leg. The deep peroneal innervates the anterior leg, and the posterior leg is innervated by the tibial nerve. Now we have the popliteal fossa. So we're going to talk about the popliteal fossa. Here, the popliteal fossa are formed by four borders. We have inferior laterally, we have the lateral head of the gastrocnemius. Inferior medially, we have the medial head of the gastrocnemius. Superior medially, we have the semitendinosus. This is the long tendon, and semimembranosus. And superior medially, we have the biceps femoris, the long and the short head. Between these all, we have the popliteal fossa. So what does the popliteal fossa contain? The popliteal fossa contains the tibial nerve, okay, the common fibular nerve, so tibial nerve innervating the posterior compartment. The common fibular nerve will give us the deep and superficial, and then we have the popliteal artery and popliteal vein. So this is on the cadaver. You can see this is semitendinosus. You can see the long tendon. So whenever you see this long tendon, semitendinosus. And then we have the semimembranosus. Then we have, this is on the medial side. The lateral side, we have the long head of the biceps femoris and the short head of the biceps femoris. Then we have the gastrocnemius on both sides. Between them, we have the tibial vein. This is the popliteal vein, okay? Popliteal artery. And this you can see here, the only thing you can see here are the popliteal artery and the popliteal vein coming from the femur. So what is the blood supply of the leg? So here we have the tibial nerve, as we said, so tibial nerve and the popliteal artery. The popliteal artery, once it exits or in the popliteal fossa, once it exits, it gives two things. It gives the anterior tibial artery, okay, and then continues to split into two, the fibular artery and the posterior tibial artery. Okay, so here you can see the popliteal artery, as I told you, first it will give a branch to the anterior tibial artery, and then it will continue to split into two things, the fibular artery and the posterior tibial artery. So what is the clinical of the lower limb? So if we have foot drop, so we talked about flat foot when we have damage or dysfunction of the posterior tibial artery. Yes, the foot drop, flat foot. The foot drop is when we have the common peroneal nerve damage. So when you have common peroneal nerve damage, we have foot drop, inability to lift the front part of the foot. Blood supply. What is the blood supply of the legs? So we have the femoral artery will give us the popliteal artery, as I showed you. The popliteal artery will divide into two things. It will first give a branch to the anterior tibial, which supplies the anterior compartment from its name. Anterior tibial supplies the anterior compartment, and then continues as the dorsal pedis artery, which is found between the first and second. You can palpate it between the first and second toes, or the first web space, and then it will continue and divide into and will continue to give us the posterior tibial. Posterior tibial will divide into the fibular artery, which will supply the lateral compartment. The posterior tibial will supply the posterior compartment. From its posterior tibial supplies posterior compartment, fibular artery supplying the lateral compartment. The nerve supply. So in the nerve supply here, we have the common fibular and the tibial nerve. So as we said, the tibial nerve supplies the posterior compartment. The common fibular will split into two things. It will give us the deep fibular nerve and the superficial fibular nerve. The deep fibular nerve will supply the anterior compartment, and it will give sensory innervation to the first web space. The superficial nerve will supply the lateral compartment and will give sensory innervation to the lower leg and dorsum of the foot. So it will give sensory innervation to the lower leg and dorsum of the foot. So now I am done with my PPT. I will recap a bit. So we have in the legs, we have the anterior, posterior, lateral compartment. Okay. In the thighs, we have the anterior, middle, and posterior compartment. And in the gluteal, we have the deep and superficial compartment. So the one thing you can do is you need to identify the muscles, the actions, okay, group them as, because it's easier to group them as who does the abduction, who does the adduction, who does the knee flexion, who does the extension, and so on, and associate them with the nerves and the arteries. This will help you memorize in an easier way and connect all the dots together. So when you're solving a question and you're reading the scenario, you know what is so for example, this bone is damaged, or this insertion bone is damaged. So which muscle is being damaged, which nerve is being damaged, which artery is being damaged. So you need to link all these together. Now we have questions. So this is a question for you guys to pose and solve. And then this is the answers. So and here you can see this is the anterior compartment. Okay, you can see here we have the rectus femoris. This is the medial side. This is lateral. First, identify first. What do you do first? Identify what's medial, what's lateral, and then identify the muscles. So here we can see this is the medial. This is the lateral. This is the anterior. This is the anterior side. So we can see here we have the rectus femoris, lateral vastus lateralis, vastus medialis, and then you can see this is the sartorius muscle. This is the pectineus muscle, and this is the answer. And for this one, you can guys pause and answer it alone. So this will be as we said, this is the gluteus maximus, gluteus medius, and then we have here the piriformis and obturator internus. This is the sciatic nerve. So we have the piriformis going through the greater sciatic foramen, and then the obturator internus going through the internal sciatic foramen, and we have the sciatic nerve here. And that's it for the OSPE review of the MSK. I wish you guys benefited from this OSPE review, and you can do it, inshallah. If you have any questions, any concerns, you can text me or text Mustafa on our WhatsApp. And thank you. This is the feedback.